Okay, ladies, so this is a review of chapter 24, and this one is drugs used to treat angina pectoris. So the learning objectives for this chapter is to define angina pectoralis and identify assessment data needed to evaluate an anginal attack, differentiate between chronic stable angina and unstable angina and the drug therapy used for each type. Describe the actions of the drug classifications used to treat angina and the effect on the myocardial tissue of the heart, and to identify risk management and healthy lifestyle changes that are taught to prevent disease progression and myocardial infarction or death. So, angina pectoralis is chest discomfort arising from the heart due to lack of oxygen to the heart muscle. Variable presentations may be squeezing in the chest, pressure, tightness, choking, burning, a heaviness, and it may radiate to the neck, the shoulder, the jaw, or the jaw. Precipitating factors are physical activity, exposure to cold, drinking caffeine-containing beverages, smoking, emotional stress, sexual intercourse, eating large meals. Symptoms of coronary artery disease caused by plaque buildup in the blood vessels, atherosclerosis, or a spasm of the artery. Attacks may last from 30 seconds to 30 minutes and are often described as feeling like someone or something is sitting on the chest. Moving on to slide 4. So, the types of angina. Chronic stable angina is precipitated by stress or exertion, and it has a short duration. It's relieved by rest or nitroglycerin. Probable cause, fixed atherosclerotic obstruction. So, arterial blocking in the arteries, when we kind of spoke on that in one of the other chapters. Unstable angina is unpredictable. Changes in frequency, duration, and onset. The probable cause is atherosclerosis and thrombus formation. Variant angina occurs at rest, is characteristic ECG changes. Probable cause, vasospasms of the coronary artery. So treatment, the goal is to prevent myocardial infarction and death and relieve pain. Alternatives to drug therapy is a coronary angioplasty, coronary artery bypass, graft surgery. Patient education, avoid precipitating factors, reduce risk factors, and exercise. Symptoms must be caught early so quality of life can be improved and life can be prolonged. Risk factors include diabetes mellitus, hypertension, and dyslipidemia. I'm on slide number 6. So, drug classes to treat angina. There are nitrates, beta-adrenergic blocking agents, ACE inhibitors, calcium channel blockers, fatty oxidase enzyme inhibitors, statins, platelet active agents. Nitrates are the oldest of all the drugs and are very effective. Combination therapy is beneficial for many patients. Statins have become a standard in drug therapy. So learn those statins, ladies. The nursing process, I'm on slide number 7. The nursing process for anginal therapy, you have to obtain a history of attacks. What are their precipitating factors? Characterize the attacks. Is central nervous system involvement? Is there cardiovascular signs? Obtain medical history, prescription drugs, ask about their prescription and non-prescription drugs, effect of agents used on attacks. How well is the medications working? Obtain nutritional history and try to find out if they have a history of high cholesterol. So CNS involvement may be in the form of confusion, restlessness, or irritability, as well as syncope and anxiety. Cardiovascular signs include palpitation, peripheral pulses, and vital signs. So moving on to slide number 8. Let me move to slide number 8. So these are the nitrates. Nitroglycerin is the most common drug used in this class. It decreases oxygen demand on the heart. It dilates arteries and veins. It reduces blood volume, and it decreases preload on the heart. The use, drug of choice to treat angina pectoralis. Common adverse effects is excessive hypotension, prolonged headache, tolerance with longer acting nitrates. Drug interaction, ED drugs like Viagra, ED erectile dysfunction like Viagra can potentially lower blood pressure. So for these specific drugs, see table 24.1. Patients can develop tolerance, especially when large doses are administered frequently. Nitrate-free periods are necessary. As patients become adjusted to therapy, headaches usually diminish or go away. Drugs used for erectile dysfunction, such as Viagra, are contraindicated because a fatal drop in blood pressure may occur. So moving on to slide number 9 in chapter 24. Still talking about nitrates. Administration forms. So nitroglycerin comes in the form of a sublingual tablet. It dissolves rapidly, primarily for acute attack or quick onset. Sustained release capsules, tablets, ointment, transmucosal tablets, and transdermal patches used prophylactically to prevent the attacks. Those particular ones, sustained release capsules, tablets, ointment, transmucosal tablets, and transdermal patches can be used prophylactically to prevent angina attacks. There is also a translingual spray for acute attacks and prophylaxis. Amyl nitrate for inhalation and intravenous form. Please inform your patient of medication deterioration. Every 6 months, nitroglycerin prescription should be refilled, and dark colored glass containers should be used for storage to preserve the integrity. So moving on to slide number 10. We're still on nitrates. Sublingual use for emergencies. Have patients sit or lay down. Place the nitroglycerin tablet under the tongue. Allow to dissolve without swallowing saliva immediately. If chest pain is not relieved within 5 minutes, seek medical attention. While waiting for emergency care, take one tablet 5 minutes later. If unrelieved in 5 minutes, take another tablet, or have the patient take another tablet. Let's move on to slide number 11. And we are still in nitrates. Sublingual use under the tongue. We're still talking about that particular one. Discard medication after 6 months and obtain a new bottle. Store tablets in original dark colored glass container with tight lid. Carry nitroglycerin at all times, but not in pocket directly next to the body. Determine if agency policy permits nitroglycerin at bedside. The nurse is still responsible for determining the effectiveness of using this. So you still have to follow up with the patient to make sure that it's working. So let's move to slide number 12, and we are still in nitrates. Transdermal patch administration. So this is a patch that we apply. Allows for controlled release of the nitroglycerin. Let me say it again. Don glove and apply this to clean, dry, hairless, intact skin. Don gloves and apply this to clean, dry, hairless, intact skin. Don't shave hair or apply to scars, skin folds, or wounds. If this dislodges, replace it with a new disc. Sublingual nitroglycerin may be given for acute attack. Remove for 8 to 12 hours to avoid tolerance. So the patch should be removed every 8 to 12 hours to keep the patient from building up a resistance or tolerance to it. Dispose of used passes out of reach of children. So slide number 13. And we are still talking about nitrates. Intravenous nitroglycerin administration. This is used in acute care areas, requires constant monitoring of vital signs. Use an infusion pump for accuracy and titration. This cannot be mixed with other medications. Use special nitro tubing to avoid plastic sets absorbing the medication. Okay, you all can answer slide 14 is question number 1. Slide 15 is question number 2. Slide 16 is question number 3. Slide 17 is question number 4. So I'm going to jump to slide 18, and we are now going to review beta adrenergic blocking agents, okay? So the action of beta adrenergic blocking agents is to block beta adrenergic receptors in the heart and to reduce myocardial oxygen demand and reduce blood pressure. It's used to reduce the number of angina attacks and reduce nitroglycerin use. Patients with acute MI or myocardial infarction should receive beta blocker. Therapy should start at low doses and work upward for patient tolerance. Combination therapy with nitrates is more effective than using either drug alone. Some of the common ones you may see in this class is propranolol, atenolol, and cardidiolol. Slide number 19 is a question. Let's see. So I'm going to move to slide number 20. And the drug class here is calcium channel blockers. So calcium channel blockers, they inhibit the flow of calcium ions across the cell membrane. They reduce peripheral vascular resistance, and they improve coronary blood flow. They're used to reduce incidence of myocardial infarction, secondary prevention for patients with known coronary artery disease. So, potent vasodilators, they have an overall effect on myocardial activity. Should be used with caution. The calcium channel blockers should be used with caution in patients who may be developing heart failure. Please refer to table 24.2. And some of the common meds you may hear in this drug class are Norvasc, Cardizem, and Procardia. Okay, let's move to slide 22. I apologize. Slide 21. So, my thing didn't jump. Okay, here we go. Slide 21. Okay, so this drug class is angiotensin converting enzyme, or ACE inhibitors. They promote vasodilation, they minimize cellular aggression, and prevent thrombus formation. They're used to reduce incidence of MI, secondary prevention and they're used for secondary prevention for patients with known coronary artery disease, or CAD. Also recommended for patients, these are also recommended for patients with MI or heart failure with left systolic dysfunction. Adverse effects such as dizziness, tachycardia, and fainting may occur within 3 hours after the first several doses. One of the common ones in this class is lisinopril. Okay, so that was angiotensin. So I'm going to move to slide number 22. Okay, so this drug class is the myocardial cell sodium channel blockers. This class, the myocardial cell sodium channel blocker, the action of this med is the enzyme modulator that affects the metabolism within myocardial cells to reduce oxygen demand. Is used to treat chronic stable angina. Some common adverse effects are dizziness, headache, constipation, and nausea. This class is often used in combination with calcium channel blockers, beta blockers, or nitrates. It does not affect the blood pressure or heart rate. It does prolong the QT interval, and it does not reduce symptoms of an acute attack. So when you're educating your patients, slide 23. Correct use of prescription medications. So you have to educate your patients to use these medications correctly for them to be effective. Common adverse effects from prescription medications. Tell your patients the most common adverse effects they may experience with this particular class. Educate your patients to avoid fatigue and cold weather. Educate your patients that lifestyle modifications may need to be made. Stop smoking if necessary. Always stop activity or exercise when chest pain is present. Educate them to stop exercise when chest pain is present. And have the patient complete a patient self-assessment form so they can tell you where they feel they are in their healthcare process. It often helps to use a pill organizer if they are having combination medical therapy. Rapid lifestyle adjustment can lead to feelings of depression. So sometimes, if this is new for a patient and it's a rapid lifestyle adjustment, they may have some depression. And allow patients and families to verbalize their feelings. And the last slide is questions, which we will be doing Tuesday after class. So this concludes chapter 24 on drugs used to treat angina pectoralis.